Namaste, good morning. Now we are on the stage of HPT hormones related videos. In last video, we have learned about the in last video we have learned about the TSH, DRH, and thyroid hormones. Now we are particularly take the learning on T3, T4, and calcitonin. These are the thyroid hormones. So T3 triiodo. Before that, there is T4 is a very important and crucial hormone for the diagnosis of thyroid hormones. So T4 is on main function of the T4 is conversion to T3. T4 is a tetraiodothyronine, means there is a four iodine molecules in that chemical in that hormone. So when there is a deiodination occurs of T4, it converts into T3 triiodothyronine. It is a major role of the T4 in the body. So uh, let's so there is a this only information is available in the medical science about the T4. Now T3 is a major hormone that is controlling the metabolism of our body and other functions of thyroid hormone, thyroid glands. So major functionable hormone is a T3. So we are learning about majorly learning about the T3 triiodothyronine. Triiodothyronine, also known as T3, is a thyroid hormone. It affects almost every physiological process in the body, including growth and development, metabolism, body temperature, and heart rate. Production of T3 and its prohormone thyroxine T4 is activated by TSH, which is released from the anterior pituitary gland. This pathway is a part of a closed loop feedback process. Elevated concentrations of T3 and T4 in the blood plasma inhibit the production of TSH in the anterior pituitary gland. So whenever there is a elevated T3, T4 in the blood, then the TSH is suppressed or inhibited from the anterior pituitary gland. And whenever there is a T3, T4 is in the low concentration in the serum blood level, then TSH is increased from TSH production is increased from the anterior pituitary gland. As concentrations of these hormones decrease, the anterior pituitary gland increases the production of TSH, and by these processes, a feedback control system stabilizes the level of thyroid hormones in the bloodstream. T3 at the cellular level, T3 is the body's more active and potent thyroid hormone, as we have already talked on the introductory session of this video. T3 helps deliver oxygen and energy to all of the body's cells. So whenever body is going into the stress effect, like when there is a excess cortisol secretion from the body, that is a stress hormone. T3 is also produced by the thyroid as well as from the T4. So T3 is a major T3 helps to deliver oxygen and energy to all of the body cells. So it is a major hormone uh, that is helping in stress effect. Its effects on target tissues being roughly 4 times more potent than those of T4. It is a more potent means it is a very powerful hormone than the T4, 4 times powerful than T4. So from spiritual spiritual point of view, we every day we have to thankful to our T3 to give the energy and oxygen to all the our body cells in the stress effect as well as in the normal body function. So every day morning while we are waking, we have to thankful to the T3. Of the thyroid hormone that is produced, just about 20% is T3. From the thyroid gland, T3 is produced about 20%, while 80% is T4. In thyroid hormones, 20% is T3 and 80% is T4. Roughly 85% of the circulating T3 is later formed in the liver and anterior pituitary by removal of the iodine atom from the carbon atom number 5 of the outer ring of T4. So already I have talked about this that T4 is converted into T3 by removing the iodine atom from its molecule. The concentration, in any case, the concentration of T3 that is formed in the liver, this process is occurred in the liver, and 85% of circulating T3 is formed from the liver. So in stress effect, also there is a role of liver in any case. And in any case, the concentration of T3 in the human blood plasma is about 1/48 that of T4. And in any case, T3 is a potent and a more active hormone, but its value in the serum level is 1/48 of T4. In T4, high concentration of serum level is a T4 and low concentration is T3. Whenever you check the report of the patient, T3's normal value is lower than T4 because T4 can convert into T3. Majorly, it is formed from T4. So T4 must be higher level because whenever there is a stress effect, every time if there is a high concentration of serum T4, then it will be directly converted into T3 and our body gets necessary oxygen and energy, all the cells. So how this beautiful system created by this nature is working all together. The half-life of T3 is about 2.5 days. T3 will be decomposed within 2.5 days, and half-life of T4 is about 6.5 days. Then it start getting decomposed and converted into different amino acids or in different molecules like carbon, iodine, etc. T4 synthesis from T4. T3 is the more metabolically active hormone produced from T4. T4 is deiodinated by 3 deiodinase enzymes to produce the more active triiodothyronine, more active T3 that is produced from the T4, and there is a 3 enzymes, deiodinase enzymes is responsible. One, type 1, present in the liver, kidney, thyroid, and to a lesser extent, pituitary. It accounts for 80% of the deiodination of T4. Type 1 enzyme, deiodinase enzyme, is responsible for 80% of conversion of T4. Type 2 is present in the CNS, in pituitary, brown adipose tissue, and heart vessels, which is predominantly intracellular. This type 2 deiodinase enzyme is predominantly intracellular. In the pituitary, it mediates negative feedback on TSH. In the pituitary, it controls the negative feedback on TSH. Type 3 present in the placenta, CNS, and hemangioma. These in hemangioma, there is type 3 deiodinase enzyme. So whenever there is a hemangioma patient are coming, then you have to check these thyroid function test. These deiodinase converts T4 into reverse T3, which unlike 3T3 is inactive. These enzyme converts T4 into reverse T3 that is very inactive. That is not like active T3, but it is an inactive T3. T4 is synthesized in the thyroid follicular cells as follows. In the thyroid gland, 20% of T3 is synthesized from the thyroid gland. So what is the process? The sodium iodine symporter transports two sodium ions across the basement membrane of the follicular cells along with an iodine ion. This is a secondary active transporter that utilizes the concentration gradient of sodium to move iodine against its concentration gradient. Iodine is moved across the apical membrane into the colloid of the follicle. Thyroperoxidase oxidizes iodine to form the I radical. Means it converts the active iodine into the radical iodine. In some cases of thyroid disease, uh, endocrinologists do one investigation, thyroperoxidase antibody, because it convert thyroperoxidase antibody inhibit this process of free iodine active molecule to the iodine radical molecule. So active iodine again combine with the T3 and make T4. So T3 again becomes low and patient is suffering from hypothyroidism. So whenever there is a hypothyroidism, you have to check all these parameters from the patient's serum level, thyroperoxidase antibody. Fourth, the thyroperoxidase iodinates the tyrosyl residues of the thyroglobulin within the colloid. The thyroglobulin was synthesized in the ER of the follicular cell and secreted into the colloid. ER means ER is a receptor. So ER is a receptor of the follicular cell and secreted into the colloid. Thyroglobulin is synthesized in the ER, then secreted into the colloid of the thyroid. Uh, Thyroid stimulating hormone TSH is released from the up to this process. There is no role of TSH, but now TSH is released from the anterior pituitary gland, binds the TSH receptor GS protein coupled receptor on the basolateral membrane of the cell and stimulates the endocytosis of the colloid, in which there is a secretion of thyroglobulin. So already there is a thyroglobulin by the mechanism of the thyroid gland. It is already produced in the colloid, and now colloid endocytosis of the colloid is stimulated by the TSH, and the endocytosed vesicles fuse with the lysosomes of the follicular cell. The lysosomal enzymes cleave the T4 from iodinated thyroglobulin. These vesicles are then exocytosed, releasing the thyroid hormones. Now, from the TSH stimulation of endocytosis of the colloid, these endocytosed vesicles fuse the lysosomes of the follicular cells. Lysosomal enzymes cleave the T4 from the iodinated thyroglobulin, and now this T4 is released. The T direct synthesis, the thyroid gland also produces small amounts of T3 directly, about 20%. In the follicular lumen, tyrosine residues become iodinated. Follicular lumen tyrosine residues become iodinated. This reaction requires hydrogen peroxide, iodine bonds, carbon T3 or carbon 5 of tyrosine residues of the thyroglobulin in a process called organification of iodine. The iodination of specific tyrosines yields monoiodotyrosine MIT and DIT diiodotyrosine. One MIT and one DIT are enzymatically coupled to form T3. The enzyme is thyroid peroxidase. One of the investigation related to thyroid diseases, especially TSH or goiter, these blood test, thyroid peroxidase antibody, I think. Serum thyroid peroxidase antibody is also another test to see the process behind the hypothyroidism or defective thyroid function. So these are the point why we are learn about the synthesis and metabolism of the T3, because we have to diagnose at which level the function is at the stake and the body is responding as a hypothyroidism. So as a homeopath, we have to understand at that cellular level which process is in the difficult state. So we can easily identify the problem, and it's also understand the psychology of the patient behind that process. Effects or functions, T3 effects or functions. T3 increases the basal metabolic rate and thus increases the body's oxygen and energy consumption. Its function, what is the function? It increases BMR, basal metabolic rate, and thus increases body's heat production, energy production, and oxygen. The base BMR is the minimal caloric requirement needed to sustain life in a resting individual. T3 acts on the majority of tissues within the body, with a few exceptions, including the spleen. It increases the synthesis and activity of the sodium potassium ATPase pump, which normally constitutes a substantial fraction of the total cellular ATP expenditure without disrupting transmembrane ion balance. So this T3 also increases synthesis and activity of the sodium potassium ATPase without the disrupting of ion balance. In general, it increases the turnover of different endogenous macromolecules by increasing their synthesis and degradation. Effects on the skeletal growth, thyroid hormones, all are, especially T3, are essential for normal growth and skeletal maturation. So, whenever there is a thyroid function is affected and become diseased, then our overall tissues are affected because it has an effect on the whole body, because it provides energy and oxygen to all the cells of the body. So one of the effects on the skeletal growth is normal growth and skeletal maturation. Like whenever there is a patient regarding the height issues or normal growth affection, then we have to think about, is the thyroid function is proper or not. They potentiate the effect of growth hormone and somatomedins to promote bone growth, epiphyseal closure, and bone maturation. So whenever there is any patient coming to us with any complaints regarding the body, then two axis is working behind any conflict or any problem with the body or psyche. One is HPA and second is HPT, because these two axes controlling that hormones that is helping during the stress effect. So these two axes, HPT and HPA axis, is very important to understand the patient while in disease. So during the fetal growth, they potentiate the effect of growth hormone and somatomedins to promote the bone growth. Somatomedin is affecting the somatos while they are structuring our vertebral column and also the bones. Epiphyseal closure and bone maturation, these are the effect of the T3 on the skeletal level. Protein, effects on the protein. T3 stimulates the production of RNA polymerase 1 and 2 and therefore increases the rate of protein synthesis. It also increases the rate of protein degradation. And in excess, the rate of protein degradation exceeds the rate of protein synthesis. In such situation, the body may go into negative ion balance. Means in stress effects, while patient directly comes in the shock, in hospitals, they do one direct report is ABG, where they can easily understand the ion balance, whether it is negative ion balance or positive ion balance by diagnosing acidosis or alkalosis. So whenever there is a stress effect, either protein degradation increase or protein synthesis increase. But whenever there is a protein degradation exceeds the rate of protein synthesis, the body goes into the negative ion balance. On lipids, effects on lipids, T3 stimulates the breakdown of cholesterol and increases the number of LDL receptors, thereby increasing the rate of lipolysis. But T3 stimulates the cholesterol breakdown, so it controls the cholesterol in the serum level and it increases the number of LDL receptors, so increases the rate of lipolysis. So T3, overall T3 controlling the lipid profile. If there is a high LDL level, it means somewhere T3 is not working properly. So body you have whenever there is a high LDL, then one of the factor regarding high LDL is a T3. So whenever you are facing this type of patients, then you have to understand the patient and doing the test consciously. So patient, you can directly uh, you can directly point out the problem behind these effects. That is that we are showing in the blood test. Effects on heart: T3 increases the heart rate and force of contraction, thus increasing cardiac output by increasing beta adrenergic receptor levels in myocardium. It increases the heart rate and the force of contraction. How much force is needed? That is, and how muscles myocardium will contracted. That is also controlled by T3. If high T3, then muscle contraction is high because body is in the smooth muscles contraction is high because body is in the stress effect, fight or flight. So heart have to pump fast in the stress effect. So force is increased, contraction of force is increased by T3 because T3 is needed in stress effect, thus increasing cardiac output by increasing beta adrenergic receptor levels in myocardium. How it affects the myocardium? By increasing the beta adrenergic receptor levels in the myocardium. These results in increased systolic blood pressure and decreased diastolic blood pressure. Systolic blood pressure uh, is increased during T3 activity, stress effect. The later two effects, diastolic blood pressure is at when the myocardium is at rest. So whenever there is a stress effect, systolic pressure will go high, but diastolic is stand still or become lower because at the time because there is a no room for rest, no time for rest. So diastolic pressure becomes low and systolic pressure becomes high. The latter two effects act to produce the typical bounding pulse seen in hyperthyroidism. The latter two effects act to produce the typical bounding pulse seen in hyperthyroidism. Because of these lower diastolic pressure and higher systolic pressure, there is a dichrotic pulse, double double pulse. Typical bounding pulse is seen in hyperthyroidism. It also upregulates the thick filament protein myosin, which helps to increase contractility. A helpful clinical measure to assess contractility is the time between QRS complex. You can judge the clinically the patient of this contractility is a time between the QRS complex. What is the time of QRS is denoting the contractility of myocardium. The second heart sound, QRS complex and second heart sound means as QRS and next P, that is a next heart sound. That is that time will give you the exactly hint about the contractility of myosin. This is often decreased in hyperthyroidism. This is often decreased in hyperthyroidism. There is a thyroid function is at a high level. So T3 is more in the body. So it means heart is in the higher constant contraction. Contractibility is high, force is high, heart rate is high. Means heart is frequently contracted and relaxed, contracted and relaxed. So So there is a less time between two pulse, QRS complex and next heart sound. So there is a lack of time between two sound. T3 effects on development. T3 has profound effect on the developing embryo and in infants. Uh, we have also seen that the one enzyme is produced from the placenta, and that is also that is converting the T4 to T3. So T3 has profound effect on the developing embryo and infancy. It affects the lungs and influences the postnatal growth of the CNS. It also affects the lungs and influences the postnatal growth of the central nervous system. It stimulates. So when the baby pass down from the birth canal, uh, baby is going into the stress effect, and due to that stress effect, because baby's body is now going through the unknown world that is not known by the baby, and the stress become high. Stress effect is going into the body. T3 is highly present in the serum level. It affects the lungs, and baby got his first breath. How these beautiful systems are working together for the survival of life, and influences the postnatal growth of the CNS. It stimulates the production of myelin, the production of the neurotransmitters, and the growth of axons. It is also important in the linear growth of bones. Each and every system of the body is affected by T3. Neurotransmitters, how it affects the neurotransmitters. T3 may increase serotonin in the brain, in particular in the cerebral cortex, and downregulate H5HT2 receptors based on studies in which T3 reversed learned helplessness in rats and physiological studies of the rat brain. Because in the studies on the rat, these T3 reverses the feeling of helplessness that is created by the lack of serotonin. Lack of serotonin creates helplessness feeling in the body. Physiological function. T3 physiological function. Thyroid hormones act to increase protein turnover, means protein balance. These might serve an adaptive function in regard to long-term calorie restriction with adaptive protein. When calories are in short supply, reduction in protein turnover may ameliorate the effects of the shortage. So whenever there is a uh, uh, calories, ATP or energy is in the short supply, while we are going into the fast, uh, when we are going into the fast, our T3 produced at the lower level, because body got lack of calorie, lack of energy. So to shut down or to reduce the protein turnover, thyroid hormones has to decrease. Protein turnover means protein depletion. Uh, so this is physiological function whenever we are in the we can say in the fast phase. So in primary era, before few years, endocrinologists do the thyroid test on the empty stomach after fasting of 12 hours. So exactly at that time, all functions are decreased. So easily diagnosed hypothyroidism. But that is not the right thing to diagnose hypothyroidism. If in the daytimes when body consumes calories, when body got energy from the food, at that time if thyroid function is at the normal level, thyroid test is in the normal level, then you can say thyroid function is normal. So whenever you go to do TSH, T3, T4 thyroid functions test, then you have to do it in the daytime, any daytime, not at the fasting time. So this is all about the T3. Now calcitonin. Calcitonin is also secreted by thyroid gland. Calcitonin is a 32 amino acid peptide hormone, protein hormone, secreted by parafollicular cells. T3, T4 is secreted by follicular cells, while calcitonin is secreted by parafollicular cells, also called as C cells of the thyroid or endostyle in humans and other chordates in the ultimopharyngeal body. So it is produced by the C cells of the thyroid. It acts to it acts to reduce blood calcium Ca plus to calcitonin. From the name itself, you can understand that it controls the calcium level of the blood, opposing the effects of parathyroid hormone. PTH, it opposes the parathyroid hormone, which parathyroid hormone increases the calcium level in the blood, while calcitonin reduces the calcium level in the blood. Its importance in humans has not been as well established as its importance in other animals, as its function is usually not significant in the regulation of normal calcium homeostasis. It belongs to the calcitonin-like protein family. Calcitonin is formed by the proteolytic cleavage of a larger pre-propeptide, which is the product of the CALS1 gene, CALCA. It is functionally the antagonist with PTH, parathyroid hormone, and vitamin D3 because both two stimulates the calcium production in the blood. The calc1 calca gene belongs to a superfamily of related protein hormone precursors, including the islets amyloid precursor protein, calcitonin gene related peptide, and the precursor of adrenomedullin. These are the family of superfamily of related protein hormone, and from that family, calc1 gene is belong. Secretion of calcitonin is stimulated by two processes, by increase in serum calcium. Whenever there is a serum calcium increased, calcitonin is produced by the thyroid hormone. And whenever there is a gastrin and pentagastrin is secreted, calcitonin is secreted with this. Function, the hormone participates in a calcium metabolism. In many ways, calcitonin counteracts parathyroid hormone and vitamin D3. More specific, so whenever there is a vitamin D3 deficiency in the serum, you find, then you have to do calcitonin. So you can judge the exactly where is the problem. You directly cannot give vitamin D sachet or anything else, but you have to see where is the problem behind vitamin D3 deficiency. If a person is in the very good condition to have healthy food and drink, if it is a medium, lower to medium or medium family, financially medium or lower to medium family or high family, then you have to go behind the vitamin D3 why it is in the low condition. So you can judge the where is the exactly problem is uh, stay in the body. Where is the problem in the body? Calcitonin function, more specifically, calcitonin lowers the blood calcium level uh, in two ways. Major effect inhibits the osteoclast activity in bonds which break down the bond. So whenever we are going into the, according to Dr. Hammer's learning, whenever we are going into the severe self-devaluation conflict, calcitonin will be increased, which decreases the osteoclast activity in the bone, and our bone will be fractured. So whenever there is a fracture, there is a calcitonin is responsible. Minor effect inhibits renal tubular cell reabsorption of calcium and phosphate, allowing them to be excreted in the urine. So whenever there is a minor effect is on the renal stone and renal stone, whether it is a phosphate stone or calcium stone, whenever these are excreted in the urine, then there is a excess calcitonin secretion. It inhibits the renal tubular reabsorption of calcium. So it is excreted in the urine and it is deposited by the deposited into the calyx of the renal pelvis, and it forms gradually it combines and forms the stone. So it is a it have a role to create a calcium stone or phosphate stone. In its skeletal preserving actions, calcitonin protects against calcium loss from the skeleton during periods of calcium mobilization, such as pregnancy and especially lactation. In its skeleton preserving action, one is a breaking down of bond, and the other function is to protect against calcium loss. So whenever there is a calcium loss, like during pregnancy and lactation, calcitonin are decreased from calcitonin production as decreased due to the negative feedback. The protective mechanisms include the direct inhibition of the bond resorption and indirect effect through the inhibition of the release of prolactin from the pituitary gland. The reason provided is that prolactin induces the release of PTH, parathyroid hormone, related peptide, which enhances bond resorption. So how it wall body is affected. Wall body is helping each other to manage the situations like pregnancy and lactation. In that situation, calcium mobilization is very fast and very in a high activity. So in these type of situations, in these type of physiological situations, our skeleton is a lady's skeleton is preserved by inhibition of bond resorption and inhibition of the release of prolactin from the pituitary gland. The reason is that prolactin induces the release of parathyroid hormone related peptide, which enhances bond resorption. So while a lady become pregnant and lactation, serum calcium is increased because serum calcium is needed to produce milk. So, so calcium is mobilized from the bond to the breast gland to produce lactation. So prolactin is a major hormone with that induces the parathyroid hormone, which increases the serum calcium and bond resorption. So to produce the milk, we body tries to suppress the prolactin level. But whenever baby and about how prolactin works. That are the different part, and we are covering in the next video topic. Another clinical significance, clinic calcitonin assay is used in identifying patients with nodular thyroid disease. Calcitonin, we have to do serum calcitonin level when there is a nodular thyroid gland. It is helpful in making an early diagnosis of medullary carcinoma of thyroid. Malignancy of parafollicular cells, that is medullary thyroid cancer MTC, typically produces an elevated serum calcitonin level. So today we hold this lecture because of the time permission, and now at the end of this video we are thankful to you. We are continue our learning in the next video session. Thank you. Goodbye. Take care.